Good afternoon, everyone. It's exactly 12 o'clock, and I'd like to welcome you to the Fairbanks Lecture Series in Clinical Ethics, which we've been hosting for the past 11 or 12 years. My name is Paul Helft. I direct the Fairbanks Center for Medical Ethics, and it's a pleasure to welcome you to our series, which is open to everybody. We'd like to welcome our colleagues who are joining us through recorded and broadcasted connections from IU Health Ball Memorial Hospital, from West, North, and Arnett. Just a reminder to silence your pagers, cell phones, etc. There's phones actually across the lobby on the back end of the foyer here, where you can find if you need an in-house connection. There will be just a few announcements. There'll be a phone number to text questions to from our broadcast sites at the very end of this lecture. We'll leave a little bit of time for questions for Jane when she's done. September 6th will be the first lecture of the year coming up. Bernice Pescosolido from IU Bloomington, will be our speaker. And then just a reminder that September 22nd, if you'd like to save the date, our second Clinical Ethics Conference, which is a semi-annual, I should say, every other year conference that we're holding as a fellowship reunion conference, will happen on September 22nd of this year. That will be our second conference. Our speaker has no conflicts of interest to disclose. Now, it's my great pleasure to introduce Jane Hartsock, who is a visiting assistant professor of medical humanities and health studies at Purdue University, Indianapolis. She graduated from Butler University in 1999 with a BA in English literature with a concentration in writing. She completed her JD in 2002 at the Indiana University School of Law at Indianapolis before moving to Chicago, where she spent more than 10 years defending hospitals and clinicians in medical legal litigation. And most recently, she completed our clinical ethics fellowship in clinical medical ethics at the Fairbanks Center, and is just about a few days away from completing her master's degree in philosophy with a concentration in bioethics on May 14th of this year. And I just wanted to share with you, I feel like I had a very small part in the trajectory of Jane's career, because I wrote her a letter of recommendation when she was applying for her faculty position at IUPUI, and I just want to read you a few of the, this was one of the more vigorous letters that I've ever written. Here's a couple of things I'd like to share with you personally about Jane. So I said, to begin, the personal characteristics which make Jane a superb candidate include her dogged and tireless pursuit of deep understanding of issues she engages with, her desire to achieve clarity of understanding, and her meticulous attention to detail. She's one of the most compelling, hardworking, brilliant, and meticulous scholars I've had the pleasure of working with in the nearly 20 years of academic work. So it's a great pleasure to welcome you here, and I can't wait to hear what you have to say, Jane.
All right, so I'm going to talk today about a survey project that I have been working on that's actually still in data collection mode, but it has to do with the way the general public views the patterns of travel that people undergo for purposes of obtaining an organ transplant. So these are my no disclosures, basically. All right, so we're going to follow kind of a little path to get to the ultimate issue of how people view this practice. We're going to begin by analyzing the legal and ethical frameworks within which organ transplantation functions. I think that helps people kind of understand and locate us within the discussion. We're going to clarify the unique ethical issues implicated by patients who are non-residents and non-citizens of the U.S. traveling to receive deceased donor organs here. I'm going to say a couple words about that in just a second, and then we'll consider the potential for a deterrence of donor registration that this practice may have. So just to kind of orient us and clarify exactly what we're talking about here. So travel for transplantation denotes a fairly broad category of patterns of access to healthcare, and it includes things like people from the United States traveling to other countries to obtain organs. It includes people who travel to the United States to donate organs. It includes, I suppose, undocumented immigrants trying to obtain organs. What I want to specifically talk about today is people who travel from other countries to the United States for the sole purpose of obtaining an organ transplant here. So that's the only reason that they're here. And it's important to kind of separate that category, that demographic of patients, from other patients because it is a category that particularly OPTN is looking at very closely, and it shouldn't get sort of conflated or confused with other categories. So I'm not talking about undocumented immigrants. I'm not talking about people who are sort of coincidentally in the United States and then happen to need an organ transplant. So people who are here on work visas or student visas, or who are here to visit family, or tourists here, you know, going to Kings Island or something. So that is not the group that I'm talking about. I'm not talking about living donation. I'm specifically going to talk about deceased donor donation, specifically because that world presents different obstacles and different considerations than the broader category of living donation. So, so it is a sort of specific group that I'm focused in on, and I just want to kind of clarify that at the outset. So, moving forward, these are the issues that I'm going to be kind of addressing today. So, keeping in mind that very narrow category or group of patients that I'm talking about, I want to look at to what extent is the general public aware that U.S. transplant centers provide deceased donor organ transplantation to individuals who are not residents and are not citizens of this country. And I anticipated that the awareness of that practice would be relatively small, because even in my conversations with physicians, they seem to be outside of the transplant community unaware that that takes place. And then, would this practice deter U.S. residents from registering as organ donors? So those are the sort of two related questions that I am looking at right now. So, so I want to give a little bit of the legal background here, because the legal picture actually informs the ethical issues. So the National Organ Transplant Act of 1984 established the only organ procurement and transplantation network for the entire country, and that's administered by UNOS. The Organ Procurement and Transplantation Network, OPTN, they monitor data, they publish policies, they oversee the organ transplant infrastructure here in the United States, and they establish the criteria for organ allocation. So the procedures by which we sort of disperse organs throughout the United States. And that act, one of the significant things that act did was establish that medical criteria only would be the sole basis on which to determine organ allocation. So this was a big change in the national picture. Prior to this time, you heard stories about things like social worth criteria informing organ allocation, and there was not necessarily a consolidated or a consistent pattern of organ donation throughout the United States. It's interesting, the history of this act in light of my area of research. When this act was being sort of drafted and argued and promulgated, the concern at the time was what to do about undocumented immigrants. And there was a question as to whether or not to have two separate lists, for example, one for people who are not citizens of this country and one for people who were citizens. And the thought process at that time had nothing to do with the issue that I'm talking about pertaining to people traveling here. The focus was really on whether, you know, a sort of ideological divide, whether or not people who were here illegally should be able to obtain organ transplants. And as a way to just sort of avoid that whole question and hand over some autonomy to transplant centers to make the decision for themselves, at the listing phase of organ transplantation, the Congress decided to just simply limit it to medical criteria and keep things kind of clean, or so they thought, right? So the idea was that if we limit things to medical criteria, then we don't have to have some kind of ideological discussion along with it. So it's ironic then that this kind of opened the door to a different group of people then gaining access to organ transplant. So the other thing to keep in mind are the policies, the organ transplant the organ procurement and transplant network policies that have to do with this particular talk. So policy 5.4a is the non-discrimination policy that governs organ transplantation in the United States, and states that a candidate's citizenship or residency status in the United States must not be considered when allocating deceased donor organs to candidates for transplantation. And then policy 17.1 has to do with registration of transplants of non-U.S. citizens and non-U.S. residents. So this is that specific group that I was, or the larger group of the group that I'm talking about. So members may not enter into contracts with foreign agencies or governments for the transplant of non-U.S. residents and non-U.S. citizens. Members may negotiate the terms and conditions under which any individual candidate would be treated, with the understanding that each candidate must be referred on a case-by-case and physician-to-physician basis. So basically, transplant centers can't enter into contract with like another country to provide organ transplantation or to give favor to that country here in the United States. So this will be familiar to the fellows who are here, right? It's interesting because so usually the ethical question precedes the legal question. That's something that those of us with our feet in both worlds kind of see, that the ethical dilemma presents itself, and when it can't be resolved, it ultimately gets litigated, and that law then informs subsequent similar cases until the analogy falls apart and something has to be litigated again. But in organ transplant, it's kind of interesting that the legal picture has given rise to additional ethical questions. So I put the law slides first. So the 4 principles of bioethics that our fellows and ethicists in the room will recognize are autonomy, non-maleficence, beneficence, and justice. And I have justice highlighted because that's really where we're going to kind of hang out for this conversation. Non-maleficence and beneficence sort of hover in the background of organ transplantation, and they certainly are frequent topics of conversation in like committee meetings at OPTN about how to design the rules of allocation. But justice is more of the issue that we'll be talking about today. And justice within the context of bioethics is distributive justice. So this is the sort of utilitarian concept that resources should be distributed in a just and equitable way. It's not, as sometimes my students say, being punished for doing something wrong. They have their exam on Thursday, and I just know I'm going to get that answer on a test. So that answer is wrong. All right, so within organ allocation, these are the sort of issues that present themselves as subcategories of this distributive justice concept. We have issues of membership, issues of reciprocity, questions of organ stewardship, augmentation of disparities existing within the organ transplant allocation system, whether our system enables or disincentivizes other countries from establishing their own self-sustaining organ transplant infrastructure, and then the issue that I'm currently looking at, which is whether there would be a deterrence to donor registration if we continue this practice. So I'm going to walk through each of these just to give a complete picture. But as I said, donor deterrence is the focus. So the question of membership is an old question, and Dina Davis wrote a sort of highly cited article about it in 1992 where she talked about membership in connection with what she called the free rider problem, and this idea of sort of people who are not part of our system pulling out of the system. I think she sort of rightly concludes that the free rider argument ought not to be used to exclude foreign nationals because it is based on fallacious assumptions about group membership and how the giving community is defined. And I think that's probably right, that defining membership gets tricky. Members to what? Members of the state, members of this church, members of this country, members of, what defines you as being a sort of member of something that it's sort of ambiguous and not a good metric for whether somebody should be able to access organ transplant. So that was a sort of early conversation that took place. Reciprocity is very much related to this, but it's a little bit different. So one of the criticisms of the membership criteria for organ donation, very early criticism of it, was that our own citizens, our own residents of this country, aren't always registered organ donors. And even now, I think the rate of people who are registered is a little over 50%. Interestingly, when I did the survey that I'm going to talk about a little bit later, as a kind of cleansing question, I just well, I've got you here, asked people, if you aren't registered, why aren't you registered? And I provided a box for people to just kind of fill out their own sort of idea, why they aren't registered. And a significant number of people thought that they weren't eligible to be organ donors, which was kind of interesting. They thought that they were too sick or too old, or that they had a pre-existing condition that would make them not eligible to be an organ donor. And then the maybe second category to that was people who thought that that it would make them more likely to have care and treatment discontinued at end of life if they were a registered organ donor, which is probably not a surprise that people still think that. But the reciprocity question has sort of different components to it, a little bit more depth than this question of membership. And one of the issues that sort of comes up when you're talking specifically about people who travel to the United States solely to obtain an organ, a deceased donor organ here in the United States, that there are a lot of ways that people participate in organ donation that they're not even necessarily aware of. So you can be a registered organ donor, and that's the sort of very obvious way, and we kind of measure that, and we keep track of that data, and so we know sort of how many people are registered. But unregistered donors donate their organs. Their family members consent to organ donation at death if they think that's in keeping with their family's values. If you are a taxpayer, you are paying for part of the funding of UNOS. So if you are sort of contributing to our economy, you are contributing to the organ donation infrastructure. If you are a consumer and sort of keeping the economy going, that as well pays for organ donation. And then even if you think of sort of insurance risk pools, how we pay for organ transplantation in the United States, if you are paying into a risk pool, for Blue Cross Blue Shield, you are paying probably for somebody else's organ transplant. And so there are a lot of ways that people can participate in organ donation without even thinking about it. And if you are part of this population of patients who comes here solely for a deceased donor organ, you really are not doing any of that. So it's not just a question of membership, sort of like, do you belong? But it's a question of participation. Are you in any way involved in the infrastructure that gives rise to our organ transplant system here? So the other question that comes up often in this area is a question of organ stewardship, and I've defined it here as the ability or predicted ability of a potential recipient to care for and make good use of a donated organ. I don't know where I got that definition, I have to confess. I hope I made it up. It's pretty good, I think. But this is something that comes up usually at the listing phase of organ donation. We give consideration to whether this is somebody who will make good use of the organ. So we have sobriety requirements. We have inquiries into whether the person has adequate social support. Do they have access to health care for purposes of follow-up care? And will they be able to comply with post-transplant care? So organ stewardship has some sort of specific obstacles within the context of travel for transplantation. For quite a long time, a lot of what has been sort of known or deduced about this practice has been shared by way of anecdote. One of the anecdote-based arguments that you often hear in support of accommodating travel for transplant here in the U.S. is that the countries, the people who are coming here are coming from countries that are too impoverished to support their own transplant infrastructure, and that you wouldn't want them, in fact, to have a transplant structure in those places because they would not be able to support the volume or the research or the training of physicians on a wide enough basis to do it well. And so there's a way in which those countries, being small and impoverished, we have a sort of ethical obligation to accommodate people coming from those places. But this gives rise to a problem then of organ stewardship, which is what happens when they return to their country of origin. Are they able to get post-transplant care? Or if they have a complication, are they able to follow up with a physician there? If they have some sort of emergency, who do they go to after they've returned to their home country? So if we assume poverty, how do we ensure that these patients have access to post-transplant care? They're here because they lack infrastructure at home. So what happens when they return? And this is important because we don't allow people here in the United States to be listed if they can't demonstrate an ability to comply or access post-transplant care. So there's kind of an irony there. And then we don't really have a way to measure what happens to these patients after they return to their home country. We don't have a real solid way of keeping track of the outcomes that they have, or how many people need retransplantation, and where they go to get that. So there's also a question, obviously, about whether poverty is actually the driving force that brings patients here. So in as much as there is anecdotal evidence that these patients are poor, there's quite a bit of anecdotal evidence that they're not. And so this kind of brings us to the history of the way this demographic has been divided up and examined within OPTN. So originally, prior to 2012, the category of people who were not residents of the United States or not citizens of the United States was this group called non-resident aliens. And as you can kind of see with that category, like, who is that? Who goes in that category? Does that include undocumented immigrants? Does that include people who are here on a work visa? Does that include students who are international students? Who goes in that category? And that's kind of exactly what transplant clinicians said, was like, we're not really sure who goes in that category. So the ability of data collection was kind of hampered, and certainly it didn't give OPTN and people who are interested in this issue the ability to really closely examine who's coming here and why and what's happening. So in 2012, OPTN divided that category into two separate categories: non-U.S. citizen, non-U.S. residents, not here for transplant, so that's your sort of students and tourists and all of that, and then non-U.S. citizens, non-U.S. residents here for transplant. And then in 2015, OPTN decided they wanted to look even more closely at that group, because that was specifically the group that they were interested in. And they began in 2015 to track the data related to exactly what countries people are coming from who fit within this category. So that's a little bit of the background. But that is just to say that we don't have a ton of information about these patterns and about who's coming to the United States and why, just because we don't have a long period of data collection with respect to this practice. But here's what we know about the non-resident alien group. So that was the group that originally existed, a little bit nebulous, not quite sure exactly who's in there. And so since that was the longest existing demographic that we studied, we do have some information about them. So we know that for this group, like 38% of liver recipients were self-pay. So that's important, right? So that's people who are able to pay for an entire organ transplant out of pocket in cash. And that's more than a third of recipients were able to do that. They were 3 times more likely to have a postgraduate degree than people here in the United States getting organ transplants. They seem to receive deceased donor transplants more rapidly after listing, although that could be the result of the fact that they might be sicker by the time they get here. They have lower MELD scores at the time of listing, but are more likely to receive exception points than citizens. They're also more likely to list at multiple transplant centers, which is an interesting sort of practice that you can imagine might give somebody a little bit of an edge. If you can list at multiple transplant centers and then travel to the one that just gets the first matching organ, that's actually what Steve Jobs did, and that wasn't received very favorably by the public. But anyway, the ability to go to multiple places, they're more likely to be men, although marginally so. And they are, for self-pay non-resident aliens waiting for a deceased donor liver, the average time on the wait list was 5.1 months, compared to, I think, 12 to 18 for a citizen. So a very short period of time. So there's some interesting factors or data about this particular group. So, I guess I actually kind of want to go back and mention that to be more explicit, that one of the things that this gives rise to is a conversation about whether this group is able to sort of leverage off of the existing disparities in our organ transplant infrastructure. So are they able to sort of take advantage of those parts of the allocation system that already at baseline benefit people with financial means and sort of augment those or exploit those in their favor? So if you are able to pay out-of-network costs for organ transplant, if you can afford extensive travel accommodations for that, you're probably going to be somebody who has more financial means. And this is interesting, particularly because there's data on the income that corresponds with mortality on the organ transplant list. So research was done that demonstrated that patients with a median income below $60,244, it's a very specific sum, were more likely to die on the wait list than those with incomes greater than that amount. So what we see is that in our own organ transplant system, it clearly favors people with financial means. And so if we're bringing people in with financial means, are we further exacerbating an already problematic system? So another thing to I guess be aware of in this practice is whether we are enabling or disincentivizing countries from establishing their own organ transplant system. So you remember earlier I suggested there's sort of two schools of thought on people who are traveling here. One school of thought is that they're from poor and impoverished countries, that those countries can't support their own transplant centers, that this is a kind of charity or good work that we're doing. The other thought is that these countries are actually not impoverished. They're really first world countries, some of them quite wealthy, and that the real issue is that the culture of those countries does not accept or embrace the concept of brain death. So brain death being a sort of necessary part of the organ transplant system. Countries that don't accept brain death will not have sufficient donation rates to support a transplant infrastructure. So where are patients coming from becomes an important question. So this is this is the deceased donor donation rates internationally. I have the top 10 countries and the bottom 10 countries listed. So Spain has 39.7 people or patient, people per million or so, I don't know, whatever. So they have 39.7 donations per million people, and they are the highest donation rate. Malaysia is the lowest in this list at 1 per million donation rates. And so you can kind of look here and see a mix of wealthy countries and poor countries. So it's nice that both schools of thought are right, that they can claim they're right. It's always nice when we can have an agreement on that. But the people who are traveling for transplant don't necessarily fit who the countries that have a low, the countries that are sort of poor and impoverished, that picture of countries that don't have sufficient transplant infrastructure because they simply don't have the financial means to support it. This is data that I requested from OPTN a year and a half ago, but in 2015 they did start tracking this data, and this is what they had at that point. This is out of 141 patients who traveled for transplant. Bill, that number's for you. I know you want to know out of how many. So 10.5% from Saudi Arabia, 4.2% from Kuwait, 2.4% from Israel, 2.1% from Mexico, and then United Arab Emirates, Qatar, and Brazil. So 69% had not reported, which I'm assuming is just the lag from the fact that they had recently started collecting the data. But anyway, so what we see is that the people who are coming here are not necessarily poor and impoverished, that they are likely to be from countries that have a significant financial means that could support their own transplant structure, at least financially. So the current place that I am in kind of analyzing this is wondering to what effect this practice of providing deceased donor organs to people who are not residents of this country, are not citizens of this country, and are likely to be people of pretty significant financial means, whether that would deter people from registering. And this is an issue that has been looked at once before that I'm aware of. In 2009, a group at the University of Michigan looked into it as part of their sort of concern that media coverage of this practice might have the potential to adversely affect organ donation. So right around this time, there were some sort of high-profile, unpopular stories about organ donation. One of them involved a Japanese gang boss getting an organ transplant at UCLA in exchange for testifying against another gang member, this sort of thing. And so that hit the newspapers. The LA Times reported on it, and it was a sort of highly publicized story at that time. It was not well received, as you might imagine. And there were already questions about, Steve Jobs, when he traveled for his transplant, he traveled from California to Tennessee. People thought that was kind of a problem. And then there were other sort of, I guess, lower profile stories. There was a story of a family that traveled from Japan and paid, I think, $1.4 million for a heart for their child. So you started to see those kinds of stories percolate up in the news, and they weren't well received. So this group looked at whether or not that media coverage was adversely impacting people's willingness to donate organs. So their survey involved 1,049 participants, and what they found was that 30% of those people believed that people should not be allowed to travel to the United States just to receive a deceased donor transplant. Some 28% thought the travel would be, I spelled a typo, that's nice. 28% thought the travel would be acceptable in some cases, but 38% would be less likely to donate if they thought that their area was a region in which people were traveling to receive an organ from another country. So that's somewhat concerning to think that people would be less likely to register. So this is what I'm kind of looking at right now. My thought process is a little different. I was curious as to whether those results would be repeated, but my thought was that increases in anti-foreigner sentiment might be driving a little bit of the conversation, might have the potential to affect organ donation. So I've got 995 responses as of Monday when I put this PowerPoint together. And 35.65% of those people thought that people should not be allowed to travel to the United States to receive a deceased donor transplant. 20% were unsure. 33.7% would be less likely to donate. And then I asked people whether what they knew about about this practice, 20.44% believed it's already illegal. So 1 in 5 people thought you can't do it legally, and only 27 thought that it was legal. I had another category of people who could say they were unsure, and so people did confess to not knowing. So anyway, it looks like it's pretty consistent, but I am curious as to whether the sort of current climate of xenophobia and nationalism might contribute to people being less likely to donate if they knew about this practice. And just sort of on that point, this is some research that was done in 2013 by Pew about people's perceptions of different countries. And you can see that there's a very unfavorable, I bet the perception of Russia has changed a little bit. But anyway, Saudi Arabia, China, Mexico, sort of, you can kind of imagine like this, those have probably stayed fairly consistent. I actually was reading an article this morning in The Atlantic that had, they'd conducted some research themselves and found that there was a 55% unfavorability towards Islam currently in the United States. So, so you've got countries, the countries that are coming here are the countries that people tend to have unfavorable views of. And so again, kind of wondering whether that will drive the people to be less likely to donate. So I guess I want to sort of make a comment on this point. So my stance on the issue of transplants in patients who are not residents and not citizens of this country is that we generally, with some exceptions, shouldn't do it. It's not going to work out well for people in the country. The article that kind of gave rise to this subsequent question suggests that we could have a kind of a system in which people who are not residents of this country could receive an organ to the extent that it was not going to be able to be used on somebody who is a resident of the country. So you could have a kind of, I mean, there is some waste in the organ transplant system, and if we can reduce waste by including people, that seems to be a no-loss situation. But I want to be clear that my view shouldn't be taken or mistaken for adherence to some kind of membership criteria. And that's not what I'm advocating, and that these days membership sort of cleaves to xenophobia and nationalism, which I find repugnant. And so there's a question then, there's sort of an embedded ethical question here, I guess, which is the extent to which we should tailor medical care or anything else for that matter around views that we might find objectionable in themselves. So if the idea is that xenophobia or nationalism might discourage people from donating organs because those organs are going to people from countries that we have an unfavorable view of, should we allow that to affect our ability to, or our willingness to provide transplants to that group? So I don't think we should have that view guiding organ transplant policy, but we should be aware of it. And it's something that's sort of lurking in the background, certainly, to this conversation. My concern actually is more the financial picture, and whether the inequity between the financial status of people who are organ recipients is a real focus that we should be paying attention to. So seeing the list of countries of people who are coming here for transplant bothers me, that those are people who are likely to be quite wealthy in a system that already favors the wealthy. So, this is also particularly troubling because we're starting to see an ever-decreasing number of Medicaid programs that are willing to cover organ transplantation. I think Arizona has stopped covering organ transplants. Their Medicaid program has. I believe Indiana still does, but we'll see. And then we also have a problem with undocumented immigrants in the United States to the extent that they are 3% of donors, but they have trouble clearly accessing organ transplant services when they themselves need them. So what I kind of come to with all of this at the end is that this picture of providing organ transplants to people who are not citizens and not residents of this country, it's a kind of unnavigable maze, right? So everywhere you turn, you kind of run into a problem with it. You can't solve one picture of it. We couldn't like change advertising to decrease people's awareness that people from other countries can get organ transplants, and that would somehow fix it. Like, it wouldn't. We still run into problems with whether poor and impoverished countries, whether they can support the kind of post-transplant care that their patients would need. We have problems with the financial picture of organ transplant here in the United States, and whether that's contributing and causing to problems with access just for people who are already here. So I think it would be a mistake to isolate a single issue and suggest that this is the problem. There's not a problem. There are several problems. And after we move through membership and reciprocity, what we find is that travel for transplantation, people traveling here for transplantation, there's not really an upshot. There's not a way to allow that to work well and not at the expense of people who are residents here. One of the things I've kind of thought about with this is this idea that there's a group of people, this sort of abstract group of people who need organs, right? And the question, of course, of allocating them is not just a question of allocating who gets the organs, but it's a question of allocating the sort of where the suffering goes, right? Like what group are you going to apportion the sadness to? And so the issue of providing organ transplant services to people from other countries doesn't reduce that suffering. It doesn't reduce that sadness. It just apportions it to a different group of people, probably people without significant financial resources to compete with that group for organs. And so ultimately, I come to the conclusion that we should not be providing these services here in the United States. And so with that, thank you. That is. Oh, and I have one funny. So, because I am a humanities professor, I have to make a Frankenstein joke with organ transplant. I have another one. Do you want to see the other one? Yeah, the other one's better, but it's not quite as on point. That's good, right? So, all right, so that's all I've got. I'd be happy to take some questions. Okay.
These are for our offsite people. If you're here, just raise your hand.
Thank you. That was a very interesting talk. You mentioned about the cases, the public notoriety of people coming in, and I can remember Pittsburgh got a lot of bad press because there was a perception that wealthy emirs were coming from Saudi Arabia and buying organs. Has anybody looked at actual fallout? Was there any decrease in people's willingness to donate in the wake of this notoriety? Have we seen any documented effects?
Yeah, I don't think anybody has looked at that, and that's a good point that you could, like look at the organ registry before, or the organ donation rate before, and then look at it afterwards and see if there was a decline. I don't think they've looked at that in Pittsburgh. I know they've actually looked at that in Europe. So this is not a system or a problem that's unique to the United States, particularly in the European Union. It is an issue that's probably exacerbated or even a greater issue because of the relationship that the European Union has, like the way the states have to cooperate with each other. But I do know that I think it was Germany was going to allow for this practice, and they did see a decline in organ donation rates Whether that would translate to the United States as well, I don't know. But I don't think anybody's looked at it in exactly the way that you're suggesting. Does that answer your question? Okay.
How does this imbalance occur between people who have more money getting more?
I don't know how it occurs. I mean, so the way it occurs is kind of I think, is kind of an indirect effect. So if you have more money, you can probably afford to go out of network. And if you can go out of network, you can register in different regions. So you could register in a region that has a higher donation rate, that does more transplants. And so the ability then to sort of pick where you want to register or to register in multiple places and be able to get there quickly, that results in a disparity. So people are able to get better access in that way. And then I think one of the good arguments that I've heard in favor of allowing people to travel for transplant to the United States is that the money that people pay out of pocket, right? So they don't have the insurance negotiated discount rate or anything like that. They just pay whatever the flat rate is. That money then can be reinvested into the transplant system, and people can then use it to do research, potentially to provide charity care to other patients. And so there's a feeling that you want those patients in your center because they'll be able to support other research being done. So those are kind of two ancillary issues, but I think it would be, so I guess I should be clear that I'm not suggesting that like transplant surgeons are calling, Saudi Arabia and saying, we'll charge $2 million. Do you have anybody who will take a liver or something like that? I hope that's not happening. I don't think that's happening. I think it's an indirect effect.
So in terms of registered donors, do you have statistics on the non-resident, non-citizen aliens who live here? Are the rates of registered donors any significantly lower or similar to the rest of the population?
I don't know. That data is absolutely available. Well, maybe not the registration, but the donation rates. I don't have that off the top of my head, but I think you can go to the OPTN website, and that is one of the fields available, is donors by citizenship status, and you can look at that. I don't know then if they break that up. I mean, obviously people who are coming here for transplant are not donors, but people here who are students or whatever, what their donation rate is, I don't know what that rate is, but I think I could get it. I think that data exists.
I was just wondering, I'm a social worker, and we have talked about the ethical dilemma of what the international global program here I think that they're through IU Health, what they are doing when they are reaching out. Because we've been to presentations before where they're actually saying, we're reaching out to different countries. So I didn't know, because you had ended the question previous to saying kind of like, I hope that's not happening, but I didn't know if you knew, is that what happens with the International Global Program?
So I don't know that program.
I was going to pick on him and see, does anybody else from the transplant program want to try to answer that question? Would you like to? Would you be willing to? Yeah, how about that? Perfect. Excellent. That way we don't have to speculate.
Okay, I'm Susan Money, Operations Manager for IU Health International Patient Services. appreciate your being here. This is a very interesting topic. So currently, our program that launched in 2013, in alignment with other U.S. academic health centers who are providing solid organ transplant, do promote the services to the Saudi and Kuwait embassies and to other embassies. And we are in a national organization called USKIP, which is supported by U.S. Department of Commerce. And the U.S. Department of Commerce does consider this like an export service, these medical services. So money coming into U.S. As an export to increase that bottom line. But to answer that question, yes, centers such as Johns Hopkins, Mayo Cleveland, UCLA, MD Anderson, they've been doing these types of services since the mid-1990s and have very, large developed programs like Johns Hopkins. They have 200 people working in that department. So yes, the services are promoted to the embassies. And as far as the financial situation in Saudi and Kuwait, this is a government; those are socialized countries, and the services are provided by the government. The citizens do not pay anything for these medical services that are not available in, some of them are not available in the home country. So.
I've worked here several years, about 13, 14 years, and I've met a few families over the years who've come here for medical services. And years ago, I had a family that came from Canada for their child to have a transplant and came to this region because we had a low waiting time for, I believe it was a liver at the time. I think with that and with this family, it's a reminder we live in a capitalist society, and as much as we try to do things ethically and everything in the hospital, I think money is a big part of it, and we don't have physicians often running where we work, and it does come down to money. So I thought that was interesting to bring that up, how we look to bring in people from other countries. And but then on the other flip side of that is, what would we do for our child if we had a child who needed services that were only available outside of this country, and what extent would we do? But then at the same time, there are so many people in this world who don't have any access to get help for their child, and that's the end. So.
Yeah, so I would like to, I think that's an important comment. And I guess I want to say sort of two things on that point. The first thing is that for almost self-preservation reasons, I just don't touch the child transplant topic at all. I just can't even stand it, right? Because I would totally pay $1.4 million for my daughters. I would go wherever, right? And I know that that's an issue that's difficult for the people who are the clinicians who are sort of next to those kids. My daughter was getting an echo a couple of years ago, and the person who was doing her echo was kind of talking to me about what do you do and what is that, and and so she said that a few years prior to our conversation, she'd had a pediatric patient who was waiting for a heart transplant, and she had gotten really attached to that patient, as people do, and and she recalled sort of sitting with herself and wanting to pray for that child to get a heart transplant, and then realizing what that meant, what she was praying for, right? She was praying for some other parent to lose their child, and for some other parent to not get their child a heart transplant, for this child to, sort of come up on the list first. And she just kind of didn't know what to do with all of that. So the pediatric world, I just kind of can't get too I just can't do it. I'm sorry. I'm not tough enough. But I think, as it relates to your comment about the sort of capitalist nature of healthcare, that's for me anyway, where this issue of disincentivizing countries that could support transplant from doing it. So one way to reduce the suffering would be to increase the number of people who get transplants. And one way to do that is to encourage other countries to develop transplant programs. And Japan is actually a good example of a country that has responded to that external pressure. So Japan had very, very low transplant rates, tied largely, I guess, to cultural views about brain death. And in response to, I think, the Declaration of Istanbul and some of the conversations that took place internationally about whether there would be a crackdown on travel for transplant just internationally, they made a sort of like almost a public service announcement push to increase people's acceptance of brain death, and they have seen an increase then in willingness to donate organs. So the sort of peer pressure effect, even within a sort of semi-capitalist framework, can work. And so I guess that's how I would respond to the second part of your comment.
Thanks for your presentation, Jane. You mentioned earlier the argument that increasing international transplantation may increase revenue that then gets redistributed for other good causes. Did you run across any research where we're actually exploring that, and is that taking place?
No, that's based on an anecdotal argument that was made to me. I don't have any research on that.
Jane, you'll probably stick around a couple minutes in case anybody wants
Sure.
to come up, and thanks so much for everything.
Thank you.